Hello everyone, and welcome to today's webinar in the Public Health webinar series on blood disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. I'm Christopher Beam, and I serve as Hemostasis Laboratory Branch Chief in the Division of Blood Disorders at the CDC. I'm pleased to be with you and serving as today's moderator. Today's topic is laboratory testing for inhibitors in the changing landscape of hemophilia treatment products. So before I introduce our guest speaker, I've been asked to go over a few points and helpful tips for joining and enjoying this webinar. So upon joining the webinar, you would have seen two audio options. You can opt to listen via the speakers on your computer or by using your phone to call in. If the phone option is chosen, the webinar toolbar will provide you with the phone access number and audio pin. So during the presentation, all audience audio will be muted. At the end of the presentation, there will be time for questions. And to submit a written question, please use the questions area of your toolbar. And our presenter will respond to as many questions as time allows. Today's webinar will last approximately 1 hour. And please note that the webinar will be recorded. So right before we get started, we're going to begin today's webinar first with an audience poll because we're very interested in knowing more about you, the audience, who's tuning in. So we would greatly appreciate your participation in this first question which has come up. And we'll give it a minute for people to respond. Okay, so that's great. It looks like we do have some people from outside the US, so that's wonderful. Thank you. So we have another question coming up. Okay, that's super. That looks like we have quite a range of people, including a whole lot of people who provide care to people with bleeding disorders. So that's great news too. And now we have just, I think, one more question. If you would participate, that would be great. Okay, great. So that's great. I see we have a lot of people from our HTCs. So welcome everybody. Now, finally, it's my pleasure to introduce today's presenter, Brian Boylan. Brian is a research biologist in the Division of Blood Disorders at the Hemostasis Laboratory Branch at the National Center on Birth Defects and Developmental Disabilities at the CDC. After earning his master's degree in biology at the University of Wisconsin-Milwaukee, Brian worked for 10 years at the Blood Research Institute in Milwaukee, studying signal transduction in platelets as it relates to bleeding and thrombosis. Brian joined the Hemostasis Laboratory Branch here, the CDC, in 2010, where he continues to work in research and development in the area of inhibitor testing. He has authored multiple papers describing a novel assay to detect anti-factor VIII and factor IX antibodies in patients who have hemophilia, as well as studies characterizing the performance of clot-based assays for detecting inhibitors. His papers on these topics are published in Hemophilia and the Journal of Thrombosis and Hemostasis. So now, Brian, welcome, and let's begin.
Thank you, Chris, for that introduction, and thank you to the organizers for giving me the opportunity to talk here today. And what we'll be speaking about is laboratory testing for inhibitors in the changing landscape of hemophilia treatment products. And I have no conflicts to disclose. An outline of the talk is shown here, and I'll begin with a brief introduction on hemophilia and the evolution of hemophilia treatment, and then talk about inhibitors in hemophilia and laboratory testing for inhibitors, and finally new products, and discuss how the new products fit into the inhibitor testing framework. And I'd like to begin by showing a picture of the coagulation cascade, just to give us a frame of reference, and not to mention many details, but to point out that the coag cascade can be initiated in a couple of different ways. You either have a damaged vessel surface or some sort of trauma that initiates a series of biochemical events leading to clot formation. And to orient us, when we talk about hemophilia, we'll be speaking about mostly factor VIII and factor IX. And so with that as a backdrop, hemophilia are X-linked inherited bleeding disorders characterized by absent or dysfunctional factor VIII in the case of hemophilia A, or factor IX in the case of hemophilia B. And these affect 1 in 5,000 and 1 in 30,000 males, respectively. Factor VIII and IX deficiencies result in suboptimal thrombin generation at sites of vascular injury, leading to impaired clot formation. And in the absence of clinical intervention, patient morbidity is significant and is characterized by spontaneous joint and muscle bleeds, pain in the joints, which contributes to lack of mobility and often early death due to uncontrolled bleeding. Well, thankfully, there are treatments available, and I'd like to spend the next slide walking through a brief history of factor replacement for hemophilia treatment, beginning in the 1950s, when the main treatment was fresh frozen plasma. And these treatments required large volumes of plasma to stop bleeding due to the fact that factor is at very low concentration in plasma. And so these treatments took some amount of time and often required hospital admission. Then in the 1960s, Judith Poole discovered cryoprecipitate when she noted that upon thawing frozen plasma, a precipitate formed, and she demonstrated that within this precipitate there was an enrichment for factor. And so this allowed for the production of product that had more concentrated factor, and therefore smaller volumes were required for treatment, which facilitated outpatient treatment. Then in the 1970s, factor VIII and factor IX plasma-derived concentrates became available. And these were good because patients could administer product themselves and they could do so at home. Then in the 1980s, blood safety concerns and advancements in biotechnology together inspired the development of recombinant factors VIII and IX replacement proteins, the first generation of which became available in the 1990s. And then shortly thereafter, in the 2000s, second and third generation products became available. And I should mention that in the first generation products, human albumin was used as a stabilizer in the final product preparation. And due to concerns about known and emerging pathogens, the second generation products exchanged sucrose in as a stabilizer to replace albumin. And then the third generation products took this a step further by excluding all animal and human proteins from the cell culturing process as well as the final preparation. And then more recently, in the 2010s, we saw the fourth generation recombinant factor products. These are the extended half-life products. And I'll speak a little bit more about these later. And finally, most recently, just last year, in 2017, the factor VIII mimetic emicizumab was approved by the US FDA for use in patients who have hemophilia A and inhibitors. And so as you can see from this slide, over the last several decades, a lot has changed both in hemophilia treatment products and the methods to which they're administered. And these changes have translated into significant quality of life improvements for the patients. But there is a lot of work to be done, and most notably in the area of inhibitors. So what are inhibitors in hemophilia? We know that a major complication associated with factor replacement therapy is the development of neutralizing antibodies, which are referred to as inhibitors, directed against the treatment product. And inhibitor development occurs when the body does not recognize the clotting factor used for treatment, and an immune response is mounted in response to treatment product exposure. So this is a classic self versus non-self dilemma for the immune system. And we know that inhibitor development can occur when a person who has hemophilia does not make any clotting factor or makes factor that is structurally different from normal factor. And the way that this might occur is depicted in a simplified cartoon shown on this slide, in which an antigen presenting cell, for instance, a dendritic cell, encounters infused factor. That factor can become internalized and then processed by the cell, such that a portion of that molecule is displayed on the surface of the cell via an MHC class II molecule. Then this cell can encounter a naive T cell, and through a series of signaling events activate the T cell such that it's primed for interaction with a B cell that's been exposed to the same infused factor. And again, a series of signaling events can lead to T cell induced B cell maturation, a mature B cell with lasting memory, and the ability to make anti-factor antibodies. Now, we know that inhibitors occur in around 30% of patients who have severe hemophilia A, and around between 9 and 23% of patients who have severe hemophilia B. And we know that inhibitors nullify the therapeutic value of factor replacement by either interfering with product's function. So upon replacing factor VIII or factor IX, if you have an inhibitor around, you can stop the coag reaction, and even though you have adequate levels of factor around, clot formation does not occur. Inhibitors can also affect or nullify therapeutic value of replacement by facilitating the removal of product from circulation. So inhibitor development usually requires a change in treatment regimen and results in increased patient morbidity, mortality, and cost of treatment. So that's what inhibitors are. What do we know about these antibodies? We know that anti-factor antibodies can be detected in plasma samples from patients who are positive for inhibitors, but also in patients who are negative for inhibitors. And studies in our laboratory and others have shown that the best indicator for a functional inhibitor is IgG4 for patients both who have hemophilia A or hemophilia B. And data describing the antibody profiles in these patients are shown here. This is a summary of the data that we've obtained in our laboratory. Shown on top is the data for anti-factor VIII antibodies from patients who have hemophilia A, and data from patients who have anti-factor IX antibodies who have hemophilia B, shown on the bottom. You're looking at percent positives for IgG1, 2, 3, or 4 different subclasses of immunoglobulin G. And then the data are segregated by Nijmegen-Bethesda positivity. So the red bars are from specimens that tested positive by the Nijmegen-Bethesda assay, and the blue bars are from specimens that tested negative by the Nijmegen-Bethesda assay. And you'll notice that the specimens that tested positive by Nijmegen-Bethesda are predominantly positive for IgG4, whereas the specimens that tested negative are predominantly negative for IgG4. And this is the case both for anti-factor VIII antibodies as well as anti-factor IX antibodies. And so our conclusion from these data is that IgG4 is the best indicator that a functional inhibitor is present. So that's a little bit about what inhibitors are and what the antibodies look like. How do we measure them? And there are a couple of different types of inhibitor measurement methods. They fall into two broad categories: the functional assays. And the functional assays are designed to simulate conditions in the body that initiate clotting in order to detect factor-specific inhibition of the clotting process. The second main category are the antibody detection assays. And these assays are designed to directly detect anti-factor antibodies. And I'll talk a little bit more about each of these types of assays. First, the functional. So the gold standard inhibitor test is the Nijmegen-Bethesda assay. This is an assay that measures inhibition of clot formation when patient specimen is mixed with a pooled normal plasma. And I'll get more into the details in a few slides on the mechanisms that these assays use. Some of the limitations of the Nijmegen-Bethesda assay are that it can be influenced by the presence of lupus anticoagulants, other non-specific inhibitors of coag, and also heparin. In addition, this assay uses an arbitrary positive cutoff, and it can therefore lack some sensitivity at low titer. In addition, there is some problems with interlaboratory reproducibility at low titer. A second type of functional assay is the chromogenic Bethesda assay. And this assay is based on the same principles as the Nijmegen-Bethesda. But rather than measuring inhibition of clot formation, this assay measures inhibition of factor 10A generation. And most people think that it's actually less susceptible to non-specific inhibitors of coag compared to the Nijmegen-Bethesda. And this most likely is a result of the fact that this assay focuses in on a narrower portion of the coagulation cascade when compared to the clotting assay. And I'll talk more about that in a little while. So before we get into the details on the mechanisms of the assay, I wanted to provide an overview of CDC's factor VIII and IX inhibitor testing protocol. And this is the protocol that we use for our surveillance program, in which we test all of the specimens using our top-level test, the CDC's modified Nijmegen-Bethesda assay. And then for a subset of these, the specimens that fall into the low positive category, which for factor VIII is this range 0.5 to 1.9 Nijmegen-Bethesda units, and for factor IX, 0.3 to 0.9. These specimens undergo confirmatory inhibitor testing, And I will mention that this is a relatively low percentage of our samples overall. For the factor VIII, it's around 2 or 3%, and the factor IXs, it's around 1 or 2%. But these low positive specimens get a repeat Nijmegen-Bethesda, as well as, in the case of the factor VIII specimens, chromogenic Bethesda assay. And they get an anti-factor VIII or IX fluorescence immunoassay for specimens from patients who have hemophilia A or hemophilia B. And then we also do a dilute Russell Viper Venom time test. And this test is used to identify the presence of lupus anticoagulant, which can contribute to the generation of false positive results when you use the Nijmegen-Bethesda assay. So with that said, I'll move into a description of the assays themselves. Shown here in this cartoon is a depiction of the Bethesda assay, which was first described in 1975. This assay is the basis for the functional assay, all of the functional assays that we use today. And it consists of two separate reactions, a test reaction and a control reaction. And then the test reaction is a mixture of patient plasma and pooled normal plasma. And then this mixture is incubated and allowed to form a clot. And then the amount of clot formed in this reaction is compared to the control reaction, which is a mixture of, again, pooled normal plasma, and in this case, imidazole buffer. This mixture is treated in the same way as the test reaction, and then the ratio of clot formation in the test reaction compared to the compared to the control reaction, reflects the strength of the inhibitor in the patient sample. So the idea is that if the patient sample has an inhibitor in it, this inhibitor will then slow down or prevent clot formation in this test reaction, and it'll have a smaller clot compared to this control reaction. That's essentially what the question is. And so then around 20 years later in Nijmegen, they published a modification of the Bethesda assay, and the modifications that they made are shown here in red. The main structure of the assay remains the same, but most notably, they substituted factor-deficient plasma for the imidazole buffer used in the original description. And that's for the reason that factor-deficient plasma serves as a much better control for a control reagent for the patient plasma used in the test reaction. And they also added a buffering system to the pooled normal plasma to ensure that this reagent stayed close to physiological pH. And these modifications were shown to improve reproducibility in the results, especially as the results approached the positive cutoff. But then more recently, in 2012, here at CDC, Connie Miller and colleagues described a pre-analytical heat treatment step modification to the Nijmegen-Bethesda assay, in which patient plasma is heated to 56 degrees for 30 minutes prior to the reaction. And this pre-analytical heat treatment of patient samples was shown to limit interference by either infused or endogenous factor in the assay reaction. And this modification allowed for testing when washout was not feasible. So the idea being that any factor that's in this test reaction upon heating will be destroyed and therefore unable to participate and influence the clot formation that's measured downstream. And so in order to eliminate spurious results that were caused by factor in the test reaction, this heating step was added. And then finally, I wanted to describe the Nijmegen-Bethesda assay, and this is the last functional assay that I'll talk about. And this is again based on the same general structure as all the other functional assays. But the difference is that in this case, instead of measuring clot formation, at the end of the day, you're looking at factor 10A generation using a chromogenic substrate. And so in this case, the ratio of light generation, or more specifically color change in the test reaction compared to the control reaction, reflects the strength of the inhibitor in the patient sample if it's present. And at this point, I wanted to just spend one more slide discussing the Nijmegen-Bethesda assay, because this assay will become important a little bit later when we talk about the factor VIII mimetic emicizumab. And so I wanted to just show this cartoon to describe how this assay works exactly. And it focuses in, like I mentioned earlier, it focuses in on a narrower portion of the coag cascade. So the important players in the assay are factor VIII, factor IX, and factor X, as shown here in this cartoon. Now, in this assay, the factors 9A, 10, and thrombin are derived from a cow. So these are bovine reagents. And that detail also becomes important a little bit later when we talk about emicizumab. But the way that it works is, upon initiation of the reaction by addition of calcium, thrombin is activated, which activates factor VIII. Factor VIII sits down on phospholipid, and that allows it to introduce 9A to its substrate factor 10. And then activated factor 10 is generated, which can cleave a chromogenic substrate to generate a yellow color in the reaction vessel. And so what you're measuring is how much yellow is generated in the test reaction versus the control reaction. Next, I'd like to talk about antibody detection assays, and there are two main types of these that are used today. The first one, both of those are described on this slide. The first one is the enzyme-linked immunosorbent assay, and this is an ELISA, in which patient antibodies are allowed to bind to factor that's immobilized on a plastic surface. And then antibodies are detected with an enzyme-linked anti-human immunoglobulin reagent and then quantified by measuring the generation of, once again, a chromogenic substrate. The second main type of antibody detection assays are the fluorescence immunoassays. And this is the type of assay that we developed in our laboratory and have integrated into our surveillance program, in which patient antibodies are allowed to bind to factor that's immobilized on fluorescent beads, and they're then detected with fluorescently labeled secondary antibodies. And I'll just add Regarding the direct antibody detection assays, as the name implies, they directly detect factor-specific antibodies. And this detail is important because it's in contrast to the functional assays, which measure as an output inhibition of a functional event such as clot formation or factor Xa generation. But the functional assays have no ability to detect any immunoreactivity. So although the antibody detection assays can directly detect antibodies, they do not, though, have a means for determining if the antibody is neutralizing or non-neutralizing. And so because of that, these assays do require a follow-up with a functional assay for confirmation and also for quantification. And then I'll add that antibody detection assays can also be used to distinguish lupus anticoagulants from factor VIII inhibitors. And this was described in a recent paper by Dr. Rampersad at Indiana Hemophilia Treatment Center, in which members of our hemostasis laboratory branch were collaborators. And so with that, I'll take the next slide to quickly describe how our fluorescence-based immunoassay for detecting anti-factor antibodies in plasma works. It's a simple assay that requires a fluorescent bead, which is coupled then to recombinant factor VIII or factor IX, depicted by triangles. This bead is then incubated with dilute plasma samples. Any antibodies in the plasma are then allowed to bind to the factor conjugated to the bead. And then these human antibodies are detected with serial incubations of anti-human immunoglobulin, which is conjugated to biotin, followed by a detection reagent, which specifically binds to biotin with a fluorescent tag. Then you measure the amount of fluorescence in the tube, and you get an idea of how many antibodies are bound to it. So with that said, I'd like to spend the next part of the talk taking a closer look at new factor products and the implication for inhibitor testing. And for that, I'd like to start by asking a simple question: why extended half-life products? And in order to put that question into context, I've brought the coagulation cascade back, in this case to point out the level of complexity. There's lots of different factors, arrows, acceleration points, deceleration, activation, and inactivations, and all this to generate a clot. And I point this out to as a reminder that factor VIII and factor IX have physical properties that, combined with their carefully regulated on-off switches, are critical for maintaining hemostatic balance in healthy individuals and serve as checkpoints, which are important to avoid excessive bleeding on one hand and a hypercoagulable state on the other. And one of the important factors that contributes to maintaining this balance is short half-lives of both factor VIII, which is around 12 hours, and factor IX, which is 18 to 24 hours. And so those short half-lives help maintain this hemostatic balance. It was designed to function with that in mind, and that's all well and good in healthy individuals, but short factor half-lives do become a liability when the goal is to augment factor levels in patients who have a deficiency. And so therefore, increasing the amount of time that an infusion product stays in circulation is desirable in the hope that it will both decrease the burden of IV injection and also, hopefully, the overall cost of treatment eventually. And there are a few different strategies used to extend the half-life of product. One of the main types is the generation of fusion proteins. And fusion proteins are molecules that are constructed by fusing a protein of interest, for instance, factor VIII or factor IX, to a second protein, such as the Fc fragment of immunoglobulin or to albumin. Now, immunoglobulin, or antibodies, and albumin have half-lives of up to several weeks, due to a recycling mechanism that protects them from degradation. And these chimeric molecules, diffusions, are designed to benefit from the characteristics of the protein of interest, factor VIII or IX. So factor VIII as a cofactor, or factor IX as an enzyme that activates factor X, and the protein to which it is fused. And so the presence of the Fc fragment of immunoglobulin, or albumin, allows the factor fusion protein to leverage the mechanisms in place that ensure extended plasma half-life of its fusion partner, and thus extending by the half-life of the factor product. A second main type of a strategy used to extend a product half-life is pegylation. And pegylation is a modification of a molecule by addition of polyethylene glycol chains. And pegylation increases plasma half-life by improving solubility, decreasing the formation of protein aggregates, which is likely a byproduct of improved solubility, and then also acting as a shield against proteolytic degradation. So in our case, then, this would be by turning off the off switch. And then I will mention as it relates to extended half-life products that using pegylation or protein fusion products may make washout and heat inactivation more difficult, and so therefore the impact of these products on inhibitor testing needs to be explored. And studies asking these questions are currently underway in our laboratory. And next, I'd like to move on to talk about factor VIII mimetic, emicizumab. Now, emicizumab was, early on in the literature, referred to as ACE910 for antibody mimicking coagulation factor VIII, co-localization of factors 9 and 10, something to that effect. And emicizumab is currently marketed under the trade name Hemophilia. So emicizumab is a factor VIII mimetic, and it mimics the action of activated factor VIII, but it's structurally unrelated to factor VIII. And we return to the Coag cascade to orient to the emicizumab relevant portion of the reactions. And the players important here are factor VIII, again, factor IX, and factor X. And in order to get a better idea of how emicizumab works, it's important to know what factor VIII's job is. And so that's depicted in this cartoon, in which activated factor VIII, shown here in red, acts as a cofactor to bring factor IXA, shown here in green, into close proximity to its substrate. So 9A is an enzyme. It activates 10, which leads to thrombin generation and clot formation. Now, emicizumab is designed to fulfill factor VIII's role as a cofactor in the absence of functional factor VIII. And emicizumab is actually derived from two separate monoclonal antibodies, one with specificity to factor IX and the other with specificity to factor X. And through a series of clever molecular biology and cell biology tricks, they were able to create a bispecific antibody containing two different antigen binding fragments, one specific for factor IX and the other specific for factor X. And just by simply binding to its targets, emicizumab brings 9A in close proximity to 10, leading to thrombin generation and clot formation. And so this is how emicizumab fills the role of factor VIII. And it has been shown that emicizumab can perform the functional role of factor VIIIa in the absence of factor VIII, but there are some questions as to how factor VIII and emicizumab differ. And a recent paper by Lenting et al. Very thoroughly and well describes this question published in Blood last year. And I'll just summarize some of the key differences that they talked about here, in which factor VIII it's pointed out that factor VIII's half-life, as I mentioned, is only 12 hours, whereas emicizumab has a half-life of around 4 weeks. Factor VIIIa also has a higher affinity to both 9A and 10 compared to emicizumab. And also factor VIIIa is specific for 9A and 10, whereas emicizumab does not distinguish between factors 9 and 9A, nor does it distinguish between 10 and 10A. And then finally, I'll point out that factor VIII has a very carefully regulated on-off mechanism, whereas emicizumab does not have a built-in on-off switch. And another important detail about emicizumab is that it's known to interfere with the Nijmegen-Bethesda assays mechanism. And the way that that occurs is shown in this cartoon, in which when you do a Nijmegen-Bethesda assay and you have a factor VIII inhibitor on board, this inhibitor can bind to factor VIII, leading to a decrease or some inhibition in clot formation. And when that's the case, you get a positive inhibitor result by the Nijmegen-Bethesda assay due to decreased clot formation. Now, everything being the same, including the presence of an inhibitor, if you have emicizumab on board, despite the fact that factor VIII inhibitors are binding factor VIII, emicizumab can still co-localize 9 and 10, therefore bypass the stop sign that the VIII inhibitor put up, and so therefore emicizumab's ability to facilitate clotting independent of factor VIIIa renders the Nijmegen-Bethesda assay uninterpretable. And that's because you can get factor 10A generation even when factor VIII is inhibited. And for that reason, specimens from patients who are on emicizumab should not be tested for inhibitors using the Nijmegen-Bethesda assay. And so, due to the fact that you can't use a Nijmegen-Bethesda on patients who are taking emicizumab, we've added a top-level question to CDC's factor VIII inhibitor testing protocol, and that is the patient on emicizumab. And if the answer is no, we proceed as normal. But if the patient is on emicizumab, we skip over the CDC's modified Nijmegen-Bethesda assay and move straight into the confirmatory tests, which are the chromogenic Bethesda assay, utilizing bovine components, because out of a stroke of luck, emicizumab is unable to bind bovine 9A or bovine 10, and so emicizumab's presence in the reaction for the chromogenic Bethesda assay, emicizumab has no effect on this reaction, and so the results are legitimate. And we also look at the anti-factor VIII fluorescence immunoassay on these specimens, as well as the DRVBT, the dilute Russell Viper venom time, to look for lupus anticoagulants. And so with that, I will conclude by saying that a variety of methodologies are available to detect inhibitors in patients who have hemophilia. We know that new extended half-life products utilizing pegylation or protein fusions may make washout and heat inactivation more difficult, and for that reason, the impact of these products on inhibitor testing needs to be explored. And as I mentioned, we are currently investigating these questions in our laboratory. Also, the presence of emicizumab renders the Nijmegen-Bethesda assay uninterpretable, and specimens from patients who are taking emicizumab must therefore be evaluated for inhibitors using alternative methods, such as a chromogenic Bethesda assay utilizing bovine components. And then finally, clinical laboratories need to be aware of the products that patients are receiving in order to choose the correct testing method. And with that, I'd like to acknowledge members of the hemostasis laboratory branch, specifically Dorothy Ellingson, who does the majority of our inhibitor testing, as well as Jennifer Driggers, and Connie Miller, who is no longer officially a member of our lab, but she serves as a vital consultant. And I'd also like to thank Amanda and Chris. And with that, I will take your questions.
Great, thanks, Brian. That was really good. So just to remind everybody, we are moving on to the question and answer section. And to submit your written questions for Brian, you can use your the questions area of your toolbar. And just, I guess, while people maybe are doing that, I wanted to maybe ask you a question, Brian, or throw one out there. So could you tell us a little bit more about the significance of the anti-factor antibodies other than the IgG4 that you talked about?
Certainly. Yes, so as you can see from the slide, I'll go back to the figure. As you can see from these data, you can, for instance, in the anti-factor VIII antibody data, you can see that these specimens can be positive for IgG1, 2, 3, or 4. IgG2 and IgG3 have a very low percentage of antibodies positive. So the data on these, it's less predictive. And not a lot is known about what might be going on with antibodies of these subclasses. However, we and others have shown, there's a paper by Hofbauer and Blood a few years ago that looked at the affinity of the antibody response. And in that paper, they noted that if you look at patient specimens in serial samples over time, that you might see IgG1 appear early on. And there is at times a transition from IgG1 low affinity antibodies to higher affinity antibodies, and that response eventually can lead to an IgG4. We have seen similar things happen when we looked at serial samples from patients, in the case of factor VIII, unfortunately there's not a lot of data using serial samples in factor IX because they're a little bit more difficult to come by. But when you look at when we looked at serial samples from patients with hemophilia A, we did see that there was a subset of patients that had IgG1 positivity, but nothing else, and that later on they developed IgG4 as well as a functional assay, positivity in a functional assay. So there is some significance to the presence of IgG1 as well. I will note, though, that they're much more common, IgG1 are much more common in patients who are negative by the Nijmegen-Bethesda assay. So you have to be careful when you're looking at strictly IgG1 positivity.
Okay, great. And actually, a follow-up question, I think, from the audience, from the web, which I think is right related to this, is they're asking, how is the distribution of IgG1 versus IgG4 in cases of low titer Nijmegen-Bethesda inhibitors?
Well, it's a little bit hard to say when you consider all low titer inhibitors together, but if we could break down the low titer inhibitors in the patients who, let's say, for instance, are previously negative for inhibitors, those are the ones where you might see the one spike up ahead of the fours. And often the case is that in the case of a transient inhibitor, you might see one poke up and then the functional inhibitor will go away. And in that case, you might see IgG1 stick around or go away. There are all sorts of different combinations. So there's not really a good rule to use. But when you see these antibodies pop up, especially in the low titers, those are the ones that you want to keep an eye on and monitor over time to see what happens with both the functional result in the Nijmegen-Bethesda and also the antibody. And those results together can sort of guide your thoughts on the progression of the inhibitor. Now, when you look at the low titer inhibitors in patients who have a long established inhibitor, it's more common to see both IgG1 and IgG4, and you can see all different combinations of high and low titers of antibodies. But mostly, if you have a low titer Nijmegen-Bethesda, you will see some amount of IgG4, and IgG4 levels do tend to correlate pretty well, too, with Nijmegen-Bethesda units, but that's not always the case.
Okay, great. So the question comes in and a little bit different area. So do results for the Nijmegen-Bethesda and Chromogenic-Bethesda correlate well then? Could you comment on that?
Yes, they do actually correlate quite well, and especially in the case where the Nijmegen-Bethesda result is greater than, in our hands, greater than 2.0, we see that those results are positive in the Nijmegen-Bethesda and the chromogenic in almost every case. Now, when the titer gets lower and closer to the positive threshold, there's a little bit more discrepancy, and those are the ones that, and this is why we like to test our low positives in the case of factor VIII between 0.5 and 2.0. This is the reason why we like to test our low positives with multiple tests, and so that we can get as much information as possible to make sure that we get the result right. But when you're above 2, those two assays are in agreement almost every time, and they're mostly in agreement too as well when you get closer to the low end of positive, but there can be some disagreement in those specimens.
Okay, and so a related question, and probably also inspired by what you're talking about with the emicizumab, is what is the availability of the chromogenic Bethesda using bovine components?
Not very good. Unfortunately, the chromogenic Bethesda. So we use in our laboratory we use a chromogenic Bethesda made by Siemens, and we've adapted it into a CLIA reportable test. Unfortunately, I've had a hard time finding other clinical laboratories that have the means to test samples using the chromogenic version. And I've heard whispers that some of the clinical laboratories are looking into getting their own test approved to do this, but it seems to be a slow go at this point. But this is a question that we're all keeping our eye on for obvious reasons, because it seems like at this point our laboratory is the main source for getting these results. But like I said, other places are, anecdotally, I've heard that other places are looking into getting this on board. But as of right now, I don't know of any specifically that are offering it.
Okay, thanks. So this question also from the audience is, do you know of any cases in which an antibody developed against Hemophilia?
Yes, so during the clinical trials, they monitored patients for the development of anti-drug antibodies. And I believe that one patient developed an anti-Hemophilia antibody that neutralized its activity. And the trial had, I believe, 100 participants. So this is something that is on everybody's radar, but it doesn't seem to be a huge problem in these patients. But I mean, it's understandable that this is a question that patients in the hemophilia population are very interested in knowing because of the importance of inhibitor detection. So this is definitely something we are thinking a lot about and keeping our eye on. And yes, they have been looking into it, and a small number of anti-Hemophilia antibodies have been detected in these patients.
Okay, this question is a very specific question, I guess, about methodologies. So the question from the audience is, do you ever use human serum albumin?
So I'm not exactly sure what the question is getting at, but let me say this. I wonder if it's asking about using human serum albumin as a stabilizer for many of our assays, but certainly albumin is in the plasma that we're using as a mixture in the Nijmegen-Bethesda assay, but we never add it as a stabilizer in our assays. Hopefully that answered the question. If you'd like to talk more offline on that, you can send me an email.
Okay, thanks.
Sorry if I didn't answer your question.
Yeah, I'm sure we can. If there's still questions, I can follow up. We'll make sure that your contact's provided. So there's also a question asking if there's a relationship between genotype and IgG4 and 1 levels, or if that's been explored.
This is a really important. This question gets at a really broad topic, and that is how genotype influences inhibitor development. And this is yes, a question that a lot of people are asking. What types of SNPs or variations in a patient's immune response genes contribute to down the road whether or not they develop an inhibitor? And when you ask that question, it certainly will be relevant to whether or not they develop an IgG1 or IgG4. And yes, many people have been looking at this, and these are really difficult studies to do because there's such a huge variation in the population in the DNA sequences of those genes involved in the immune response, and so you really need huge numbers to get powerful data. But yes, this is certainly a question that people are looking into, and unfortunately, we don't really have at this point any definitive answers.
Okay. So I guess changing gears a little bit, could you comment on how effective the 4th generation products are at extending half-life?
Yes, so the 4th generation products, the half-life, unfortunately for factor VIII, it only is improved by about 2-fold. And one of the reasons for that is, I mean, that's still a great improvement. Twice as long is certainly 24 hours is certainly better than 12 hours. But one of the reasons it's thought that factor VIII half-life can't be extended much beyond that is that factor VIII really relies on its carrier protein, VWF, for going through the circulation. And so much that of its half-life is dictated by how long VWF around. And so you can stick an FC fragment on the end of factor VIII, but if it's sitting on VWF and VWF is being destroyed at a certain rate, then there's only so much that you can do to save factor VIII from being taken along with VWF. And so although you do get a bump, it's not as good of a bump as you would hope. And that's reflected in the difference between the factor VIII extended half-life products and the factor IXs. In the factor IXs, you get a better response. It's around a 4 or a 6-fold increase in half-life for the factor IX products.
Okay, great. Another question has come in, and this one is asking about, they say that they use an inhibitor screen test initially and subject only the positive screen samples for NBA. And they're asking, is this sort of the way you would do it, or is there a need to process all the samples by NBA? Or I think maybe if you could comment again on sort of the protocol, that area of how you would screen the patients.
Sure. The question is saying that they do a different type of screen initially.
Yes, there's not more specifics than that, but they say they do an inhibitor screen initially. I might assume, but it would be an assumption that there's some kind of initial screen, and then subject positive samples for NBA.
I see. I think that, I would say that we have considered on our end, I'm not exactly sure what the question gets at, but perhaps when you're looking at the protocol that we have, which begins with the CDC's modified Nijmegen-Bethesda assay, and then goes into repeating using these different tests, we have certainly considered the possibility of using an anti-factor antibody as the initial screen in our test. And this is something that we've thought about exploring, but there's a ton of work that needs to go into validating the usefulness of a different type of screening procedure as your front line. It's possible that would turn out to be a better way to do it, but we would have to do a lot of background to figure out if that's indeed the case. Now, it's also possible that they might be talking about decreased activity or recovery of products and looking at pharmacokinetics and using that as an indication of whether or not they should do a modified Nijmegen-Bethesda. We like to look at all the specimens. In our surveillance program, we like to test everybody once a year just to get an idea of what their specimens look like in a functional assay.
Great. Okay, well, thank you very much.
I hope that answers your question.
Yes, no, I suspect it did. That was very thorough, Brian. So I think as we're coming up here on the hour, I'm going to have to call a halt. So I want to thank you again, Brian, for a terrific webinar presentation today. And let the audience know that this webinar will be archived and the content will soon be available at CDC's Division of Blood Disorders website. And Brian, if you can pull up that slide, maybe show that, show that website. So on behalf of the Division of Blood Disorders at CDC, we are delighted you could all join us today. And we'd like to also thank the Hemophilia Federation of America for hosting our event today. So very shortly, you will receive an email asking for your feedback on today's webinar. So please respond with your comments. We're very interested in your feedback. Also, as we mentioned, if you have any additional questions about today's presentation that we couldn't get to, please contact Cynthia Sayers. Her address is on the slide, csayers@cdc.gov. And also, here's a little plug. Please join us next month on October 11th for a webinar co-hosted by the International Society on Thrombosis and Hemostasis and CDC's Division of Blood Disorders. This webinar is going to commemorate World Thrombosis Day, and our guest speaker will be Dr. Jeffrey Weitz, Professor of Medicine and Biochemistry and Biomedical Sciences at McMaster University. So thank you, everyone, and have a great afternoon.